Hey everyone, hope you all fine and in a good state. My name is Abdulaziz imad, third stage Muslim Medical College. Our seminar is entitled Oral Inflammatory Lesions and Premalignant Conditions that may occur in the oral cavity. This seminar will be presented by me and my colleague Abdulaziz Loqman. Thanks to Obaida abdulilah for helping us in preparing this seminar. This seminar is supervised by Dr. Zahraa Marwan. Special thanks to Dr. Zahraa for her endless effort. So, please keep watching. What are the objectives of our seminar? In this seminar, we'll introduce three main topics. I'll present the first two important topics. Then my colleague will continue the last one. The first one, which is the oral inflammatory lesions, including aphthous ulcers, oral thrush, and herpetic infection. The second is the most important topic, which is the premalignant conditions that may occur in the oral cavity in the form of fibromas, pyogenic granuloma, leukoplakia, and erythroplakia. And the last topic will be presented by my colleague, which is the carcinoma of the oral cavity, mainly squamous cell carcinoma. Starting with the first topic, which is the oral inflammatory lesions, including, as I said, aphthous ulcers, herpetic infection, and oral candidiasis. Aphthous ulcer. Aphthous ulcer is a painful single ulceration of unknown etiology, with a erythematous halo surrounding a yellowish to whitish fibrinopurulent membrane. So aphthous ulcer in this picture on the right appear as single ulceration consisting of whitish to yellowish fibrinopurulent membrane surrounding by erythematous halo. Causes of the aphthous ulcer is usually of unknown etiology, but may tend to be familial and may associate it with celiac disease, inflammatory bowel disease, and Behçet disease. Epidemiology of the aphthous ulcer. This ulcer affects up to 40% of the population. They are more frequent in the first 2 decades of life. Treatment of the aphthous ulcer, it usually resolves spontaneously in 7 to 10 days in most cases, but can recur. The histological features of the aphthous ulcer demonstrate that there is a central ulcer, as we see in this picture, with thick fibrin bed containing numerous neutrophils, with lichenoid infiltrate consisting of histiocytes, lymphocytes, neutrophils, and eosinophils. Then in the lamina propria there is widely dilated capillaries with a slight hyperplasia of the surface epithelium. So, the histological examination of the aphthous ulcer demonstrates that there is central ulcer with thick fibrin bed containing numerous neutrophils with lichenoid infiltrate consisting of histiocytes, lymphocytes, neutrophils, and eosinophils, with widely dilated capillaries in the lamina propria with a slight hyperplasia of the surface epithelium. The second oral inflammatory lesion that may occur in the oral cavity, which is the herpetic infection, always caused by herpes simplex virus 1. It is self-limiting infection, appear as whitish to yellowish patches of bumps on the inner cheeks, tongue, tonsils, gums, or lips, so it may occur anywhere in the oral cavity. Slight bleeding occur if these bumps are scraped. Causes, as I said, it always caused by type 1 herpes simplex virus. But it's important to know that this virus is one of the viruses that not leave the body cells after the primary infection but remain in a dormant latent state, that reactivation may occur later on in the form of cold sores or recurrent herpetic stomatitis. So, primary infection may develop into secondary infection later on due to reactivation of the latent virus. Epidemiology of the herpetic infection. Primary infections with this virus typically occur in children between 2 to 4 years of age and are often asymptomatic. Most adults harbor latent herpes simplex virus 1, and this virus can be reactivated, resulting in what's called cold sores or recurrent herpetic stomatitis. Treatment of the herpetic infection. It's usually self-limiting infection present with vesicles in form of cold sore, fever blister that rupture and heal without scarring. Reactivation of the latent dormant virus may occur. These two pictures on the right show the chancre sore and cold sore. Chancre sore occur in primary infection with this virus, and cold sore occur due to activation of the herpes simplex virus when in the form of cold sore or recurrent herpetic stomatitis. The histological examinations of the herpetic infections demonstrate that the keratinocytes are multinucleated, acantholytic, with nuclear inclusions found initially in follicular epithelium, with late epidermal necrosis or full thickness acantholysis, also Schwann cells hypertrophy present. So, the histological examination of herpetic infection demonstrate that the keratinocytes are multinucleated, acantholytic, with nuclear inclusions found initially in follicular epithelium. Also, there is late epidermal necrosis or full thickness acantholysis with Schwann cells hypertrophy also present. The last oral inflammatory lesions that may occur in the oral cavity is the oral candidiasis or oral thrush. It appears as whitish to yellowish patches of bumps on the inner cheeks, tongue, tonsils, gums, or lips. Like the herpetic infection may occur anywhere in the oral cavity. Also, slight bleeding occurs if these bumps are scraped. Causes of the oral thrush. The use of broad-spectrum antibiotics that alter the normal microbiota can promote oral candidiasis. Predisposing factors include immunosuppression, specific strain of Candida albicans, and the composition of the oral microbial flora. Any change in this normal microbiota can promote oral candidiasis. Epidemiology of the oral thrush frequently occur in HIV-positive patients and more common in CD4 positive cell count, less than 200 cells per millimeter. Three major clinical forms of oral candidiasis are present, including pseudomembranous, which is the most common type, erythematous, and hyperplastic. Invasive disease with oral candidiasis may occur in the immunosuppressive individuals. This picture on the right shows the multiple whitish to yellowish patches of bumps on the oral cavity. Anywhere in the oral cavity, they are multiple, not single, and we should later differentiate them from the leukoplakia. The histological features of the oral thrush demonstrate that there is scattered neutrophil in the upper epithelium with pseudohyphae of the Candida albicans, epithelial hyperplasia, dense lymphoplasmocytic infiltrate, and many dilated blood vessels in the lamina propria, as in the aphthous ulcer. So, the histological examination of the oral thrush demonstrates that there is scattered neutrophils in the surface epithelium with pseudohyphae of the Candida albicans. Also, there is epithelial hyperplasia with dense lymphoplasmocytic infiltrate and many dilated blood vessels in the lamina propria. That was all about the first topic of our seminar, which is the oral inflammatory lesions, including the aphthous ulcer, herpetic infection, and oral candidiasis. Then I'll change to the second and actually the most important topic in this seminar, which is the premalignant conditions that may occur in the oral cavity, or what's called proliferative and neoplastic lesions of the oral cavity. Why they are called premalignant conditions? They are called premalignant conditions because their presence may increase the risk for developing carcinoma. These premalignant conditions including fibromas, pyogenic granulomas, and leukoplakia and erythroplakia. Starting with the fibroma, fibrous proliferative lesions. They are submucosal nodular fibrous tissue masses, commonly occur on the buccal mucosa along the bite line. So they are submucosal nodular fibrous tissue masses. Causes of these fibromas. They are formed when there is chronic irritation, results in reactive connective tissue hyperplasia. A treatment of the fibromas is complete surgical excision and removal of the source of irritation. As you see in this picture, we'll see the submucosal nodular fibrous tissue masses occur along the bite line in the buccal mucosa. Epidemiology of the fibromas. These lesions occur in the tongue, lip mucosa, sulcus region, and buccal mucosa, with each to be 12.9, 12.9, 32.2, 41.9 respectively. This study shows that the fibroma is one of the common oral mucosal lesions, and it occurred mostly in the third decade of life, where the prevalence is higher in female patients. So, fibromas commonly occur in the third decade of life and commonly in female patients. The histological examination of the fibromas at low power demonstrates the variable cellularity, with some areas more collagenized than others. So, fibromas in histological examinations appear as that there is variable cellularity with some areas more collagenized than others. The second, premalignant conditions that may occur in the oral cavity and increase the risk for developing carcinoma, which is the pyogenic granuloma. They are inflammatory lesions typically found on the gingiva of the children, young adults, and pregnant women in the form of pregnancy tumor. These inflammatory lesions are richly vascular and typically ulcerated, which gives them a red to purple color. And this differentiates them from fibromas. Fibromas not appear as red to purple color. Causes of the pyogenic granuloma. They are inflammatory, hyperplasia, occur due to exaggerated reaction of connective tissue to some localized minor lesion or to some underlying irritation, such as dental caliculi, poor oral hygiene, and so on. Epidemiology of the pyogenic granuloma. Although pyogenic granuloma occur in patients of any age, they are more prevalent in children, adolescents, and pregnant women in form of pregnancy tumor. Pyogenic granuloma accounts for 0.5% of all childhood skin nodules. In the pediatric age group, the mean age of onset is 6.7 years, with 42 of cases occur by 5 years. The histological examination of the pyogenic granuloma demonstrates a proliferation of immature vessels similar to that seen in the granulation tissue. And that's why they appear as red to purple colored, due to proliferation of these immature vessels. A treatment of the pyogenic granuloma. Pyogenic granuloma have three main phases. Either they regress or mature into dense fibrous masses or develop into peripheral ossifying fibroma. Usually, complete surgical excision is the definitive treatment of the pyogenic granuloma as in the fibromas. Note, in some cases, growth can be rapid and raise fear of malignant neoplasm. The third and last, premalignant conditions that may occur in the oral cavity and increase the risk for developing carcinoma, which is the leukoplakia and erythroplakia. Starting with the leukoplakia. Leukoplakia is defined as whitish patch or plate that cannot be scraped off. It's important to know that leukoplakia cannot be scraped off, and bleeding not occur if we try to scrap them. So they cannot be scraped off and cannot be characterized clinically or pathologically as any other disease. They arise in the oral cavity in the absence of any known cause. Note, these white patches seen in the leukoplakia, we should differentiate them from the white patches occur in lichen planus and candidiasis because they are not considered leukoplakia. Leukoplakia is a special condition, differ from candidiasis and lichen planus. Approximately 3% of the world's population has leukoplakic lesion, of which 5% to 25% are dysplastic and at risk for progression to squamous cell carcinoma. What are the causes of leukoplakia? Causes of the leukoplakia can include irritation from rough teeth, fillings, or crowns, or ill-fitting dentures that rub against your cheek or gum, chronic smoking, pipe smoking or other tobacco use, sun exposure to the lips, oral cancer, although rare, HIV or AIDS. Epidemiology of the leukoplakia internationally occur in fewer than 1% of the population. These two pictures show the grossly and microscopical appearance of the leukoplakia. Grossly, leukoplakia appear as smooth, with well-demarcated borders and minimal elevation. It's important to know leukoplakia appear as minimal elevation, and that will differentiate them from erythroplakia. There is no minimal elevation in erythroplakia. The histological appearance of leukoplakia showing dysplasia. Dysplasia means that there is dysplastic changes in the form of pleomorphism, hyperchromatism, increased nuclear to cytoplasmic ratio with abnormal mitosis, and loss of cell polarity and maturation. So, these dysplastic changes occur in the form of pleomorphism, hyperchromatism, increased nuclear to cytoplasmic ratio with abnormal mitosis, and loss of cell polarity and maturation. Erythroplakia. Erythroplakia is an abnormal red area or group of red spots that forms on the mucous membrane lining the mouth with no clear cause, as in the leukoplakia. The presence of erythroplakia doesn't necessarily mean cancer, but this precancerous condition has a high risk of developing into cancer. It's associated with a much greater risk for malignant transformation than leukoplakia. So, the malignant transformation more occur with erythroplakia than leukoplakia. Causes of the erythroplakia. Although the etiology is multifactorial, tobacco use, cigarettes, pipes, cigars, and chewing tobacco, alcohol are the most common risk factors for leukoplakia and erythroplakia. The typical histological and microscopical picture of both leukoplakia and erythroplakia showing that there is obvious moderate squamous dysplasia. As I said, dysplasia means that there is pleomorphism, hyperchromatism, an increased nuclear to cytoplasmic ratio with abnormal mitosis, and loss of cell polarity and normal maturation. Thank you very much for your listening. Then my colleague Abdulaziz Loqman will continue the last topic of our seminar with the squamous cell carcinoma.
Assalamu alaikum wa rahmatullah. My name Abdulaziz Loqman. Now I will complete the last part of our seminar. The squamous cell carcinoma. Approximately 95% of cancer of oral cavity are squamous cell carcinoma. 95% من الكانسر اللي يصير بالأورال كافيتي هو squamous cell carcinoma. With the remainder الجزء المتبقي 5% هي adenocarcinoma of salivary gland. Squamous cell carcinoma in aggressive epithelial malignancy is the sixth most common neoplasm in the world today. Despite numerous advances in treatment, بالرغم من التقدم في العلاج إلا أنه long-term survival rate has remained less than 50% for the past 50 years. This dismal outlook is due to several factors. هذه النظرة المخيبة طبعا انه less than 50% طبعا هناك عدة أسباب، ومن أهمها هو diagnosed at advanced stage بالمراحل المتقدمة. Pathogenesis. إذن إيش هو الباثوجينيسيس من squamous cell carcinoma؟ Squamous cancer of the oropharynx arise through two distinct pathogens. السبب الأول هو exposure to carcinogen. السبب الثاني أنه related to infection، وأهم infection هو الهيومن بابيلوما فيروس ال HPV. هذا مهم أنه يسوي squamous cell carcinoma بالأورال cavity. Carcinogen exposure mainly stems from chronic alcohol and tobacco. اللي ياخذون الكحول أو توباكو أيضا أكثر عرضة إلى السيكوموس سيل كارسينوما. هذا المخطط مهم جدا وسهل، متكون من 3 أجزاء: clinical and histological and molecular. clinical ناخذ من الليفت سايد إلى الرايت سايد. الليفت سايد اللي هو النورمال، والرايت سايد رايت سايد هو السيكويموس سيل كارسينوما. الليفت سايد هو النورمال، ثم يصير عندنا هايبربليجيا، هايبر كيراتوسيس يعني increase in the keratinocyte. ثم المايلد مودريت ديسبليجيا، ويتقدم بعد المرض يصير سيفير ديسبليجيا اللي يسمى كارسينوما انسايتو. ثم يصير عندنا سيكويموس سيل كارسينوما. لو ناخذ بايوبسي من الاورال كافيتي راح نلاحظ عندنا هيستولوجي، يعني راح نشوف النورمال ابيثيليوم مال الاورال كافيتي، ثم الهايبر كيراتوسيس اللي هي increase in the keratinocyte. المايلد to moderate dysplasia ثم severe dysplasia. الكارسينوما انسايتو طبعا نلاحظ dysplasia change of full thickness of epithelium but not extend bound the basement membrane. وهذا الشيء of epithelium، هذا الشيء ما نشوفه بالهايبربليجيا، نشوفه فقط الديسبليجيا change، نشوفه بالسيفير ديسبليجيا. أما السيكويموس سيل كارسينوما لو أخذنا هذا البايوبسي راح نلاحظ أنه أيضا يصير dysplasia change of full thickness of epithelium also extend bound the basement membrane of epithelium. آخر جزء هو الموليكولر، يعني genetic alteration. عندنا إذا صار mutation بالP16 راح يصير عندنا الديسبليجيا بالابثيليوم، وإذا صار mutation بالP53 راح يصير عندنا السيكويموس سيل كارسينوما. هاي الاثنين P16 معناته ديسبليجيا، والP53 معناته سيكويموس سيل كارسينوما. A white or red patch inside your mouth or on your lips may be a potential sign of squamous cell carcinoma. There is a wide range in how oral cancer may look and feel. The skin may feel thicker or nodular, or there may be a persistent ulcer or erosion. This picture histological patterns demonstrating numerous nests and islands of malignant keratinocyte invading the underlying connective tissue stroma of oral cavity, range from well-differentiated keratinizing neoplasm to anaplastic وممكن sometime sarcomatoid tumor. Squamous cell carcinoma may arise anywhere in oral cavity, most commonly in the ventral surface of the tongue, the floor of mouth, lower lips, soft palate, and gingiva in early stage. This cancer may appear as raised, firm, pearly plaques, or irregular, or roughened, or verrucous mucosal thickening. Either pattern may be superimposed on background of leukoplakia or erythroplakia. As these lesions enlarge, they typically form ulcerated and protruding masses, يعني مثل الوارت بثرة, that have irregular and indurated or rolled border. Histopathologic analysis has shown that squamous cell carcinoma develop from dysplastic precursor lesion. What is the factor that can increase your risk of mouth cancer include? طبعا 95% 95% هي squamous cell carcinoma. الأولى هي التوباكو, use of any kind, cigarette أي نوع كان, and the heavy alcohol and excessive sun exposure to your lips, and a sexual transmitted virus اللي هو أهم واحد ال HPV, weakened immune system. إذن هذه الخمس فاكتور تسوينا increase risk للcancer of oral cavity. Tobacco, alcohol, and exposure to the sun light for a long time طبعا, sexual transmitted virus اللي هو human papilloma virus, and last one is immune system weakened. And thank you very much for your attention. If you have any question, please write it in the comment.